They intubated her, and she has past medical history consistent of coronary artery disease and MSTEMI in 2012, history of stent and heart catheter, hyperlipidemia, coagulopathy due to steroids and acute problem she has, hypertension, paroxysmal AFib, and peripheral artery disease. She has a family history of hypertension and stroke on the mother's side and MI on her brother's side. Social history, she's retired, lives with her son. She didn't know tobacco or alcohol use. Pertinent labs include elevated BNP at 154.7. Her lactate's elevated, but it has recently gotten better to at 1.9. Urinalysis within normal limits. Her CBC is a little abnormal, but maybe due to her just having surgery and the leak that's going on. CPR blood glucose is 143, serum creatinine of 0.71. She has low potassium of 3.1. Her liver tests are within normal limits, and her renal function overall looks pretty good. Her arterial blood gas is a little off with a PO2 of 157. That's trending down because it was previously at over 500 earlier in her stay. PCO2 is at 30, which is low. pH is high at 7.45. She has a RAS score of -4, and her goal is -120. So she is being essentially oversedated. Her vital signs are blood pressure of 158/92 with a heart rate of 122. Proximal is good on the ventilator. She was admitted with, they found out the mesh was taken home her Lopressor, Xarelto, aspirin, Torvastatin, and a nitristat. They continued all those except the Xarelto and the nitristat in the hospital. And you can read over too.
You don't have to read all of that, that's okay. All right, that seems pretty thorough. Group 18, is there anything you would add to this subjective or objective information? Group 18 does not have anything to add at the moment. Okay. Group 12, would you add anything?
We also don't have anything to add at this moment.
Okay, so we think group 4 did an excellent job, it sounds like. I agree, they did a good job. There might be a couple other little points that we can pick up on as we go through our problem list and assess each of the individual problems. But I think that was a pretty thorough overview of our subjective and objective information. So let's go right into our problems. Let's start by identifying all of the problems. We'll have a bunch of bits to participate, and then once we've identified the problems, we can then prioritize them, and we'll go through them in a little bit more detail. I will say that this case, there are at least 15, maybe more problems that you could identify, depending on how you group them together. There are a lot of potential problems with this patient. So let's try to identify as many as we can, and then we'll really focus on the main problems for the rest of the class today. So group 1, where's group 1? What's the problem that you identified?
The guidelines state that he was, that he's not supposed to be on prophylaxis for his seizures.
Okay, so you identified seizure prophylaxis as a problem. Okay. Group 20, what's the problem you identified?
Her promoting needed to be dose decreased due to her creatinine clearance.
Okay. Group 7, what's another problem? Where's group 7?
Intracranial hemorrhage.
All right, intracranial hemorrhage. Group 8, another problem?
Respiratory alkalosis.
Okay. Group 9.
Uncontrolled hypertension.
Uncontrolled hypertension. Group 13. Atrial fibrillation. We're getting there. We've got some more to go. Group 19.
Who said that he doesn't have any pain medicine? Or, yeah, she's oversedated too, like their rash is too low.
All right, that works. Group 23.
They said agitation and delirium, and she said,
That works. Perfect. Let's see, group 3.
Hypokalemia.
Hypokalemia. Group 6.
Put hyper because when she said she was over
Should be stopped.
I can't hear you, I'm sorry.
The perioperative antibiotic.
Okay, good. So perioperative antibiotic. Group 2.
The use of propofol and her triglycerides are elevated.
Okay, so we can kind of fit that in with pain, agitation, delirium, but if you had it as a separate problem, that'd be okay too. All right, group, let's see, 5.
DVT prophylaxis.
DVT prophylaxis, that's good. Group 15. Group 15 have any other problems?
15 or 16?
We've had a bunch of them.
No indication for HIPAA?
Okay, so I think the first group kind of got that when they mentioned seizure prophylaxis, but that is one we could talk about. Let's see, so we've had a lot, there's still several I could think of. Can any other groups volunteer any problems that you've identified that we haven't mentioned yet?
She shouldn't be on aspirin.
Aspirin? Okay.
She was on the wrong K-center dose.
Okay, so I might, you could have it as separate problems. I might put all of that together in terms of a anticoagulation, coagulopathy type problem. You can fit a bunch of that together there, but I would agree with that.
She was
Any other problems?
hypocalcemic.
Say that again?
She was hypocalcemic.
Okay, calcium was a little low. Any other problems?
Do you see the heparin?
Heparin? So I think we said DVT prophylaxis. I probably put it together with that problem. Because that was what it was being used for. But that is a good point. Anything else? So when I kind of identify my problem list, I like to make sure that every medication on the patient's profile fits somewhere into a problem that we've identified. So thinking about that, can you see any medications that don't fit into any of the
At
problems
least
we've
open
identified?
looked at it, yeah.
Albuterol? Okay, what
I
problem
got a
might you,
60.
what problem might you call that it was fitted with?
No indication.
So you think we shouldn't have albuterol?
Correct.
Okay. Any other medications we haven't talked about?
Maybe it's your team.
I don't know if she necessarily still needs to be on the mannitol.
Okay, so what, if there was a problem that you could fit that into, like a medical problem, what would it be?
Increased intracranial pressure.
Okay, so that's what it was being used for. What is the disease state that she has that requires us to decrease intracranial pressure?
To the hydro and encephalopathy.
Yeah, hydrocephalus. So you might put all that together and call that a problem of hydrocephalus, and we can think about a management there, whether or not we continue the mannitol. Any other problems? So a couple others that you might think about are bowel regimen. Does she need a bowel regimen? Something we should always think about in our ICU patients, especially if they're receiving opiates. She is on mupirocin ointment. What's that for? We didn't mention that medication. So what about MRSA?
It's different, like a newsroom.
So why do we use it as a table like that? I agree. Yeah, decolonization. So you might call MRSA decolonization one of your problems, since we have a medication that's treating that problem. Another problem that might be a little bit less obvious is stress hyperglycemia. So some of her blood glucoses have been okay, some have been on the higher side. So I would probably want to at least address that as an issue with her. So I call it stress hyperglycemia. Well, she's on a statin, right? We didn't mention that anywhere, did we? So her history of hyperlipidemia you might have on your problem list. And I think we have gotten all of them. So look, I'm going to read through real quick the list of all the problems that we have mentioned. And I want you guys to think about what your primary problem would be. So we talked about, just going through our list, stress ulcer prophylaxis, DVT prophylaxis, perioperative antibiotics, stress hyperglycemia, MRSA decolonization, atrial fibrillation, acute respiratory failure, pain, agitation, delirium, our intracranial bleed, seizure prophylaxis, uncontrolled hypertension, coagulopathy and anticoagulation, hypokalemia, bowel regimen, history of hyperlipidemia, and I think I got everything now. So lots of problems, right? So think about that list, and I want group number 26 to give us an idea of what you think the primary problem in this patient is. The hemorrhage? You said the intracranial hemorrhage? Yeah. Okay, group 10, do you agree or disagree?
Group 10 agrees.
Okay, so I think that would be reasonable. So in most cases, we can just identify a primary problem and then have everything else that's secondary. But in this case, since we have so many problems, let's try to pick our top 2 or 3 problems that are the most pressing for her. So I would agree with you that I would probably call her intracranial hemorrhage my primary problem. So group 24, what would you consider to be the second most important problem?
What was the first one?
We said it would be like intubation and respiratory failure, so pain, agitation, intubation.
Okay. Group 11, do you agree or disagree with respiratory failure, pain, agitation, delirium as your secondary problem? You agree? Okay. And let's come up with maybe our third problem and we'll stop there. So group, let's see, group 16, what do you think is the third most important problem?
Fidgeted the communication. Yeah.
Hypothermia. Group 14, do you agree or disagree? Where's group 14?
I can't even remember what the other one was. So pathetic.
Okay. All right, so let's go through, I'm going to show you what my problem list was. And like I said before, there's some of these that can kind of go together. So I would agree that our hemorrhagic stroke or intracranial hemorrhage is our primary problem. I kind of put this together with our hypertension. You could do this as a separate problem or together. in this case, our hypertensive emergency probably led to or caused the intracranial bleed. So that's why I kind of grouped them together here. And I also think our hydrocephalus and seizure prophylaxis could all be grouped together with our hemorrhagic stroke. Or if you had these as 4 separate problems, that would be okay too. You want to just make sure that you address each of these components at some place in your assessment plan. I would agree that acute respiratory failure and our ventilator management, pain, agitation, delirium that go with our ventilator management would be the secondary problem. Beyond that you could argue for moving things up or down on the list. I put our atrial fibrillation and our coagulopathy a little bit higher on my list because that's kind of the part of the contributing factors that got her here into the hospital with the intracranial bleed. So addressing that coagulopathy and what we're going to do with anticoagulation is important. But I can see how correcting the potassium might be something that you do a little bit more acutely, so it would be reasonable to move that up on your list as well. All of our other problems are things that you want to address for this patient that would be a little lower on your list. Are there any questions about the problem list or how I identified problems for this case? I think mine were pretty similar to what you all came up with, which is great. Any questions? All right. We'll come back to this problem list again as we go through the cases. Through the problems. So for class today, I want to make sure that we really thoroughly discuss these first 3 groups of problems. Anything beyond that will just be bonus. We'll get through as much as we can, but my goal for today is to make sure we discuss these 3 issues really thoroughly, and then other things we can get to as time permits. Or if you have specific questions about other problems, we'll definitely address those as well. So for our first problem, so for each of our problems, we'll go through just like you do on your sheet. So I filled out the same sheet, and we'll be following it as a guide. So for each of our problems, we'll want to do a thorough assessment by identifying and describing the problem. So this is where your subjective and objective information related specifically to that problem would go in your presentation. So you might think about lab, imaging, vital signs, findings from the physical exam, and current medications related to that problem. For the explanation of your problem, we want to think about your treatment goals and any relevant clinical practice guidelines that you may have used in helping to assess the problem. And then we'll discuss your specific plans and monitoring recommendations. So we'll kind of go through each of these 4 sections for each of the problems. So our first problem was the intracranial hemorrhage. And we can group together kind of all of our neurologic issues here. So the hydrocephalus, the seizure prophylaxis, and hypertension could all be grouped together within this problem. So could group 21, could you give us your assessment of our intracranial bleed?
We had a CT scan.
All right, so what would the CT scan show us? Group 21, are you still there?
Notice the location of the bleed.
Okay. So it identified that there was a bleed and showed us the location of it. Any other things that would go into your assessment?
You talking about when?
What? Talking about here.
Oh, never mind.
Wait. Share.
No.
Group 17.
Well, I
When
don't
your
know
assessment?
much, that's why I heard drunk. I thought you were talking about when.
What are we assessing?
I'm sorry. I'm sorry. Are we just talking about the first
I
passages?
don't know.
I don't know.
Is this the first problem?
The intracranial hemorrhage. Yeah.
We need to assess how much blood she lost and what her current brain state is.
What?
I don't know.
Everything.
No, I don't have any.
We don't have any. Do we have anything to
Talking to my group. Does anybody have anything written down for the assessment?
of the
Group 17?
What?
We're here, we're just discussing.
Okay, just wanted to make sure you're with us.
I was gonna repeat the question.
just what's the
Wait, what?
Assessment for, I think she just wants an overall assessment, right? Well, she had one because the CT said so. They already mentioned the CT. She's getting hand cough. Okay, we got black and.
We can't do this that's her mental status and she's out. You can say like her hypertension like attended to it.
Do what?
You could say like her hypertension and her Xarelto was stage too high.
Yeah, her Xarelto was.
I like this global.
Her Xarelto's coupled with her uncontrolled hypertension probably led to that.
Okay, so I think that's definitely a fair assessment, that the combination of the uncontrolled hypertension with use of a therapeutic anticoagulant led to the
One
intervention
campus.
of patient. I think that's a great assessment. Are there any other pieces of objective or subjective information that would be relevant to assess related to this problem? So group 22.
Can you repeat the question?
Sure. Is there any other objective or subjective information that's related to this problem in particular that we would want to assess? So it might be some objective information that we already heard at the beginning, but if we want to think about it in relation to this particular problem. So any lab, physical exam findings, where you talked about the imaging, any lab, physical exam findings or medication that are related to the intracranial bleed that we wanted to include in our assessment.
The patient's on Xarelto.
Okay. So I think for the last group, it mentioned that the combination of the Xarelto and the hypertension probably led to the bleed. So are there any lab values you might look at related to the Xarelto?
I mean, I feel like it's easy to include blood pressure, but then also.
Look at the coagulation screen in the labs.
Okay. What did that tell us?
Is that the one you mentioned? Is that the one
It looks like everything's normal, but if we could, we could get like a 10A assay.
Sure. So if our lab had those capabilities, that might be informative piece of information to have. All right. So group 25. Are there any physical exam findings related to the intracranial bleed that we would want to assess?
Maybe it should be like the end of the week. No. What?
So those aren't physical exam findings. That's part of our laboratory results, but I agree that those would definitely be informative for a patient with any type of bleeding. We want to look at their hemoglobin and hematocrit.
When it comes
Is there any?
Tuesday, Wednesday, we should go.
Say that again.
Do you work tomorrow?
The CT.
So we have our imaging from the CT scan. Anything from the physical exam?
She's weak on the left side.
Okay, so she has bilateral weakness.
She she's weak on the left side.
What kind of physical exam would you want to do to assess the status of a patient with an intracranial bleed?
Oh, I'm sorry.
Was it the Glasgow coma scale?
Yeah, that's definitely part of it. So in general, we want to assess their neurological status, right? How is their neurologic status? We want to do a full neuro exam, and one part of that is the GCS, or the Glasgow Coma Scale score. Does anyone know what GCS is, or how you determine the score, or what this patient's score was?
It was 5, so she's in a coma.
Okay, so what is the score range? You know?
Not that to the left. Okay.
3 to 15.
3 to 15. So the lowest is a 3, the highest is 15. So you, by no means do you need to memorize this score, but it is something that we would commonly use, would be used to assess the neurologic exam. So when you see a score like that, it's good to just kind of familiarize yourself with it if you don't know about it already, give an idea of what it is. So the Glasgow Coma Scale score assesses eye-opening, verbal response, and motor response. You kind of see that score here. So anywhere between 3 and 8 is considered a severe neurologic deficit. So we commonly use this after a traumatic brain injury, but also after a stroke, and we use to help assess the patient's deficits. So this patient's GCS was 5, which is, means that she does not have good neurologic function. All right, so that would go into your assessment. So we also mentioned that the patient's uncontrolled hypertension may have contributed to the development of this hemorrhagic stroke. So is there anything related to the hypertension that you would want to assess? Let's see, group. How about we go back to group 1?
Look at that. It's got a little master's cup. Let's see. Took me a minute to think. What?
The patient is currently on nicardipine 5 milligrams an hour infusion.
I was like, oh, she doesn't approve.
Great. So we have a current medication that they're receiving a nicardipine infusion. What would you want to assess with that medication? How would we know if it's working or not?
So we want to target a systolic blood pressure of 140 or less.
Great. So I would definitely have that goal as part of our assessment. So I agree with targeting a systolic blood pressure of less than 140. Did everyone get a goal of 140, or did anyone have different targets? Raise your hand if you had less than 140. So that's a few people. What's a different goal? Let's see, how about group 12? Did you have a different goal?
We had the goal of less than 140.
You also had 140? Could a group that had a different goal share with us what that goal was?
I had less than 140, I think it was wrong.
I put 160 on the quiz.
Okay. So can we go back to group 1 for a second? Where did you find your goal of less than 140? How did you get that?
It's in the guidelines for the management of spontaneous intracerebral hemorrhage
Okay.
at AHA.
All right. So we looked at guidelines related to intracranial hemorrhage. We got the goal there. So did any other groups or individuals, were you able to locate any guideline recommendations that helped with your assessment of the intracranial bleed? So one of the skills that will be important for working at patients like this is identifying resources that can help you with develop your assessment and your plan of that problem. So one of the resources that could be really useful in this case is the guideline that the first group mentioned, which are the American Heart Association, American Stroke Association guidelines for managing intracranial hemorrhage. So the guideline recommendations will walk us through really almost every component of the patient's care related to our problem, our primary problem of the intracranial hemorrhage. So identifying things like this can be really useful when you go onto your APPEs as well to help you, number one, work up a comprehensive plan for your patient, and also to help rationalize your recommendations. So I would agree that the guidelines recommend in the acute phase, targeting a systolic blood pressure less than 140. All right. So before we go into our plan and our monitoring parameters, I want to talk just a little bit about what's going on with this patient from a neurological standpoint, because some of this is a little bit confusing. We mentioned the hydrocephalus, the patient went for a surgical procedure. It can be a little bit confusing. So Teresa, tell us first what intracranial pressure is.
That's the one. I'm pretty sure there's more than 14 dots.
One of our groups mentioned previously that we use mannitol to help decrease intracranial pressure. So what is your intracranial pressure?
Isn't it just the pressure that the fluid inside the meninges puts onto the brain itself?
Essentially. So when you think about the brain, there's only a couple of components, or I'm sorry, your head or your skull. So your skull is solid, right? That can't expand or decrease with more pressure. It's solid. And then inside your skull, you have the brain tissue, you have cerebral spinal fluid, and you have blood. And so when these three components may increase, the pressure is going to increase because your skull, that cavity that there is to expand in, isn't going to change. So when we have increased cerebral spinal fluid, which happens with hydrocephalus, then we get increased pressure in the skull. So typically the goal intracranial pressure for someone with hydrocephalus is less than 20. So how about cerebral perfusion pressure? Does anyone know what that is?
$50 to $70.
Okay, so that's the goal. I agree with that. What is the cerebral perfusion pressure? How would you define it?
Isn't it the difference between your MAP and the ICT?
Yeah, you're exactly right. So the cerebral perfusion pressure is really just what it sounds like. It's the pressure, so kind of like the blood pressure that's going into the brain. And so this is the blood that's oxygenating our brain tissue, which is really important, right? We need oxygen in our brain to have good neurologic function. So cerebral perfusion pressure is your mean arterial pressure minus your intracranial pressure. So for a patient with a severe neurologic deficit, a really major hemorrhagic stroke like this, we need to make sure that we keep our cerebral perfusion pressure adequate to make sure we're providing oxygen to her brain tissue. So if you look at this equation for cerebral perfusion pressure, what are two ways that you can increase CPP?
Increasing the MAP or decreasing the intracranial pressure?
Exactly. So if we look just at our equation here, if you increase your MAP or you decrease the ICP, then your cerebral perfusion pressure will go up. So for our patient that has a severe neurologic injury and has elevated intracranial pressure from the hydrocephalus, then we want to think about ways that we can increase her MAP and or decrease her intracranial pressure so that we can maintain adequate blood perfusion to her brain. So we mentioned that this patient has hydrocephalus, and this is an abnormal increase in the amount of cerebral spinal fluid within the cranial cavity. So like we mentioned, there are only three things that are inside this space, and so if we increase the amount of cerebral spinal fluid, that will increase the pressure. And it can ultimately lead to atrophy of the brain and cause worsening neurological dysfunction, so that's a bad thing, right? So what can we do to decrease our intracranial pressure? Any ideas for how you can decrease ICP?
You can do mannitol, or you can do hypertonic saline, like 23.4%.
Exactly. So we could use hyperosmolar therapy, like mannitol or hypertonic saline, to help decrease the intracranial pressure and decrease the volume of cerebral spinal fluid in the brain. Is there anything else you could do to decrease intracranial pressure?
Is it possible to drain the cerebrospinal fluid?
You can drain it surgically. Any other ideas? So we mentioned a couple. So hyperosmolar therapy. You could also use analgesia and sedation. So having the patient, if they're agitated, they're using more, have more brain activity going on, so keeping them calm, sedated, can help to decrease intracranial pressure. And then kind of your last line from a pharmacological standpoint would be to use a barbiturate coma. You can use phenobarbital and essentially induce a coma in the patient. Our non-pharmacologic mechanisms are one, to use gravity. So this is the easiest thing to do. Everyone should get this. So elevating the head of the bed, we'll just use gravity to help decrease the cerebrospinal fluid in the brain. And then there are several different surgical procedures that you can do. These surgical procedures are not things that you need to know about, but because some of them are present in this case, I'm going to very quickly just review what they are, so that can help you to know what was going on with the patient. I would recommend, so this is a patient that was in our unit about a year ago at Piedmont Athens Regional. So some of my P4 students on rotation worked up this patient when they were on rotation. And you will oftentimes see things on your APPEs that are words or procedures or things that you haven't heard of before. So you definitely want to just quickly look those up to get a general idea of what's going on with your patient or what was done for them. So to quickly go through our different surgical options. So a burr hole is just inserting a small circular hole in the skull. So you can do just an individual burr hole on the left here that can be used to evacuate a clot, obtain a biopsy of brain tissue, or you can do a couple different burr holes that you see on the right here that are used to prepare for a more invasive procedure like a craniotomy or a craniectomy where you remove a portion of the brain, of the skull. So a ventriculostomy is how we would actually remove or drain the cerebrospinal fluid. So this is also called an extraventricular drain or an EVD. So you would insert a catheter through the skull and into the ventricle here. And then this drains out to a bag. So you see in this picture on the left, the catheter is going through the patient's skull into the ventricle. And then there's a tube that's going to this bag. And you can actually move the bag up or down to use gravity to help drain intracranial, the cerebrospinal fluid. With an extraventricular drain, you can also monitor the intracranial pressure. So in your ICU room, you'll have a screen with your continuous cardiac monitor where you see the patient's heart rate, their blood pressure continuously, their temperature, their respiratory rate. You can also see the intracranial pressure on that same screen if they have an extraventricular drain or an EVD. So it's helpful to diagnose what our intracranial pressure is and also to relieve that pressure by draining some of the fluid. So then the most invasive procedures are a craniotomy and a craniectomy. So a craniotomy is when you remove, you create a bone flap where you remove a portion of the skull. And so this now allows more space for the brain to swell. You can relieve that pressure because now it's not in the enclosed skull. There's more room for it to swell. And this is just a flap that can then be replaced. Or a craniectomy is to completely remove a portion of the skull with the same purpose of relieving pressure by allowing room for the brain to swell outside of the skull. So complicated, not things you need to memorize, but things when you see these words in a patient's chart, you should be able to just kind of quickly familiarize yourself with what went on with this patient. Okay, so let's get back to our problem of our hemorrhagic stroke. We've talked about our assessment in terms of all of the laboratory, physical exam, imaging, things that we wanted to assess. We also talked about our explanation of the drug-related or the problem would be the guidelines that we want to use, what our treatment goals are. So we talked about a goal systolic blood pressure of less than 140, and our goal intracranial pressure and cerebral perfusion pressure. So now let's talk about what our plan is. So let's go to group 4. Can you give us at least one component of your plan for managing our hemorrhagic stroke?
We said, since it was caused by partially due to the high blood pressure, we want to increase the nicardipine to further go towards that goal of less than 140 per the guidelines.
Okay. So increase your nicardipine infusion. Is there a maximum rate that you would increase it to?
Yeah, I noticed that. I saw the maximum rate. I'll have to look it up again, but the specific dose adjustment was increased by 2.5 milligrams an hour, I think.
Mm-hmm. So you could make an initial change by increasing by 2.5 milligrams per hour. Does anyone know your maximum infusion rate?
Is it 15 mg per hour?
Exactly, 15 would be our maximum. So I would increase our nicardipine infusion. With a continuous infusion like this, you can also put in titration parameters into your order with the directions for the nurse to increase by 2.5 milligrams every 15 to 30 minutes for a goal systolic blood pressure less than 140 up to a maximum of 15 milligrams per hour. So we can add those titration parameters to our order so that we can maximize the use of that medication without the provider having to go in every 60 minutes and assess whether they need to change the order, to change the dose. But I agree, that's a good plan for our blood pressure. So group 11, any other plans related to the hypertension?
We would also start by increasing the nicardipine, but we would monitor for blood pressure, improvement of symptoms, fluid status.
Okay, and those are definitely all good monitoring parameters related to the blood pressure. Would the patients, would you want them to go home on a nicardipine infusion? No. So you might at this stage go ahead and start thinking about what your long-term plan is, but I agree in this acute stage we would want to try to maximize the use of our nicardipine, the continuous infusion that we can then turn off if their blood pressure gets too low. So I agree that we want to maximize the nicardipine for now, and we could start thinking about a long-term plan for our antihypertensive therapy. So thinking about that, group 10, do you have any ideas for what you might want to transition the nicardipine to eventually? Any ideas?
No idea.
Okay, what class of antihypertensive is nicardipine? Calcium channel blocker. So it might be reasonable to transition to another calcium channel blocker since that's working for them. But you could take the patient's full history into account in selecting your agent, and at that point you could go back to your guidelines for hypertension and think about your first-line therapies and the patient's comorbidities. But at this stage, it might be reasonable to transition to something like amlodipine, since that's another calcium channel blocker, and the nicardipine was working for them in the acute setting. All right, so let's think about outside of our hypertension, other recommendations for a plan related to the hemorrhagic stroke. So group 14, what's another recommendation you have? Group 14, which campus are you on?
That's us.
You're here. Okay. So you could think about the hydrocephalus. You could think about the seizure prophylaxis. These are other parts of the management of the hemorrhagic stroke that we haven't made a plan for yet.
For the seizure prophylaxis, they gave them Keppra, and there was no indication that they previously had seizures, but it did say that seizures are likely to happen when you are treating the hydrocephalus.
Okay. So what would your recommendation be? That's a little bit more of a thorough assessment, but what would your plan be?
Discontinue Keppra.
Discontinue. So raise your hand if you wanted to continue the Keppra. Everyone wants to discontinue it? Were there questions about that?
None of us are paying attention when we have sex this morning.
So in what kind of patients would you want seizure prophylaxis?
She heard you. Maybe if they have a history of epilepsy.
Ones that have had a seizure previously, or if they have EEG, knowing that they have potential seizure activity going on.
Okay, so I definitely agree that patients with a previous seizure or patients that have demonstrated seizure-like activity, you would want to use an anti-epileptic. At that point, it's not necessarily prophylaxis, it's more so treatment, but you certainly would want to use Keppra or another agent for patients that have either currently or in the past had demonstrated seizure activity. So the place that I would find my recommendation regarding seizure prophylaxis is really back to those guidelines, those AHA, ASA guidelines for management of spontaneous intracranial hemorrhage will have your recommendation for seizure prophylaxis. And I would agree with Group 14's recommendation to discontinue the levetiracetam at this time because we don't have any indication that the patient has a history of or is currently having any seizure-like activity. Any questions about that? All right. So Group 20, what would you want to monitor related to that recommendation?
Continuous EEG monitoring?
Sure. So you could do a continuous EEG monitoring if if that was needed. You could also just monitor for physical signs of a seizure, but I think either would be reasonable in this patient, as long as in some way you're monitoring for any kind of seizure activity. All right, so we've talked about the hypertension. We talked about the seizure prophylaxis. The other component of the patient's hemorrhagic stroke that we need to come up with a plan for is the hydrocephalus. So Group 6, what's your plan related to the hydrocephalus?
We're not sure, but we decided to switch to the hypertonic saline.
Okay, so you would change the mannitol to hypertonic saline? Is that what you mean? Okay. And what would you want to monitor with a patient on hypertonic saline?
We would monitor for renal function and electrolytes.
Okay. What specific electrolytes?
Chloride, sodium, serum osmolality.
Exactly. So the electrolytes that we're giving them in the hypertonic saline, right? So we know we were going to give hypertonic saline. We want the sodium to be high. That's why we're giving hypertonic saline, right? But we don't want it to be too high because then that could put the patient at risk of adverse effects. So typically you want to keep, if you were giving hypertonic saline for the purpose of decreasing intracranial pressure, you usually want to keep your sodium less than about 155. So that would be high, but that's our goal here, is to increase it. We want to keep it below 155. All right, did Group have any other plans for the hydrocephalus? Did Group, Group 8, do you have a similar, different plan?
We could also do ventricular drainage for the hydrocephalus.
Sure, so we could do a ventriculostomy and insert an extraventricular drain. So that would help drain our cerebral spinal fluid and would also allow us to monitor the intracranial pressure. So if you did that, Group 8, what would your goal, or what would you monitor, and what would your goals be with that monitoring?
Would you monitor a CPP with a goal of 50 to 70 millimeters of mercury?
Sure. Yep, you can monitor the cerebral perfusion pressure to your goal of 50 to 70. Your cerebral perfusion pressure you would have to calculate by monitoring the MAP and the ICP, but you could do that if you had inserted an extraventricular drain. Did anyone want to continue the mannitol? Group 19. Why did you choose either to continue the mannitol or not to? What was your thought process there?
We didn't continue the mannitol
because we saw online that hypertonic saline actually proved to have better outcomes.
Okay, so you also changed to hypertonic saline?
Yes.
All right. If you were to continue the mannitol, what would you want to monitor, group 13? Great, so you can monitor the serum osmolality, and what would you want that to be less than? What number?
What group are y'all?
19.
Okay. What's she just called? 13. No, we have like that.
It would be the same as if you were using the hypertonic saline.
I was just saying what
So anyone can
Yeah,
help
less
us.
than 320.
Yeah, less than 320 is good. So I think any of those plans for the hydrocephalus would be reasonable. You would definitely want to elevate the head of the bed to use gravity to help decrease your intracranial pressure. It would be reasonable to change to hypertonic saline or to continue mannitol. I agree that there is some evidence that hypertonic saline is a little bit more effective than the mannitol, but it's not very compelling evidence, so you could make an argument either way. In either case, you would want to measure monitor the serum osmolality, and with your hypertonic saline, you'd also want to monitor sodium for sure. And then you could also consider an extraventricular drain to help drain that fluid. So I think all of those are reasonable. Other things that you might want to monitor related to the hemorrhagic stroke. So we said blood pressure. We talked about all of our lab values related to our therapy to decrease intracranial pressure. You would also want to monitor do a neurologic exam. So these patients will usually get neurochecks or a neurologic exam every hour initially while they're requiring ICU care. And you'd also want to repeat your head CT to see if your hemorrhage is stable or if it's getting larger. So those would all be important monitoring parameters. So are there any questions about the patient's hemorrhagic stroke and hypertensive emergency before we go on to our next problem? Question?
For the quiz for mannitol monitoring, we're looking for, I know like osmolality was an answer, but since you're also monitoring sodium, could monitoring electrolytes be considered an answer too?
So with hypertonic saline, you would want to monitor the sodium, but with mannitol, there would be a need to. You would want to monitor the osmolality. Any other questions? All right. So let's go on and talk about what, I can't remember which group it was, but one of our groups identified as our second priority problem, which is kind of combining our acute respiratory failure and ventilator management. So let's go to group 3. Could you give us an assessment, thorough assessment of this problem?
Okay, so the patient is on the ventilator. She's not breathing over the ventilator, so she can't breathe on her own. There's 4 spontaneous breaths. Looking at her ABGs, the oxygen pressure is high, the carbon dioxide pressure is low, HCO3 is low, the pH was high at 7.5 and is now at 7.45. And so she has respiratory alkalosis.
Okay. All right, so let's see, group 22. That group told us that the patient was not really breathing over the ventilator. What does that mean? Or how did they get to that assessment?
Because her respiratory rate's the same as the ventilator setting.
Excellent. So the ventilator has a set rate of 12. So we have told the ventilator that it should breathe 12 times, that it should have the patient breathe 12 times a minute. And her actual respiratory rate is around 12. It went up to 16, so maybe she had a couple of spontaneous breaths. But for the most part, her actual respiratory rate was the same as the ventilator rate. So that tells us that she's really not able to breathe on her own, that the ventilator is doing all the work for her. Good. Group 16. Was there anything that you'd like to add to our assessment of the patient's respiratory failure and ventilator management? Okay, so with the ventilator management, let's also think about pain, agitation, and delirium. Do you have an assessment related to that? You may have had it as a separate problem, which is totally fine, but let's group it together for now and add any assessment for pain, agitation, delirium. Okay, so she's currently receiving propofol and some hearing morphine. Why did she get that one-time dose of neuromuscular blocker? Can anyone help us with that?
To be intubated. To be intubated.
For what? So it's not necessarily for surgery.
It's RSI. To be intubated.
Yeah, so that was part of our rapid sequence intubation. So she got a dose of sedation and neuromuscular blocker for a rapid sequence intubation, which they probably did. They, in some cases, might do that in surgery. In this case, I believe it happened prior to surgery because of her altered mental status. All right, so is there any other objective data related to pain, agitation, delirium that we could assess? How about group 21?
I don't think we have anything to add.
Okay. Did any other groups identify any other objective data related to pain, agitation, delirium?
Her REPS score is -4, but her goal is -1 to 0, so she's oversedated.
Okay, the RAF score is -4. Do we have any assessments of pain or of delirium?
It said the nurse was unable to do it because she's unconscious and she couldn't really assess it.
Okay, so those were documented as unable to be assessed. All right, so I think that's most of our objective data for our assessment. So when we think about the explanation of our problem here, that's where we want to think about any kind of guidelines or other resources that we can use here, as well as any treatment goals or therapeutic goals. So can group 5 provide us your explanation in terms of any guidelines you would look at or any treatment goals related to the ventilator and pain, agitation, and delirium?
We use the SCCM PIDIS guidelines, which stands for Prevention and Management of Pain, Agitation, Sedation, Delirium, Immobility, and Sleep Disruption.
Excellent. So the SCCM PADIS guidelines are our new updated guidelines for pain, agitation, and delirium. So that those would be helpful. I think someone already mentioned previously what our RAS goal was, so I would put that in our explanation here, that our goal RAS was a 0 to -1. Do we have any other goals for this patient in terms of their treatment? What would your goals be for pain and for delirium?
The goal pain level would be 0, but I think we can't assess it because she's unconscious.
Okay. So we have a goal of no pain, and let's talk a little bit more about the assessment. So let's go let's go ahead and talk about how we could or should assess pain in this patient. So we had, maybe two groups mentioned that pain couldn't be assessed because she's currently unconscious. So group 15, are there any methods to assess pain in patients who are intubated and can't verbally tell you their pain score?
Vitals?
So some people would look at vitals. They can give you an indication of pain, but they're very non-specific. So they're not recommended for use in assessing pain, at least not alone. Are there any other objective measures to assess pain?
Can I retract my previous statement and say that you use the critical care observation tool?
Yeah.
Pain observation tool.
I think Dr. Brandon taught you these, right? Yeah. So the CPOT, or the Critical Care Pain Observation Tool, is an objective tool that can be used to assess pain in intubated patients that can't respond to you. So you don't need to memorize what it is, but there are 4 different categories where you can get a score of 0, 1, or 2, and that will give you your overall CPOT score. So the CPOT as well as the BPS, or Behavioral Pain Scale, are 2 different scales that are recommended by those SCCM guidelines to assess pain in our intubated patients. So although in our chart for this patient, the nurse hadn't assessed pain, we actually could assess pain, and that way we can do a better job treating any pain if it is present. All right. So what about delirium? Is there a way we can assess delirium in this patient? Group 24? Sure. Is there a way that we could assess delirium in this patient?
Is it the CAM assessment tool? We're not really sure.
You're next. The CAM-IC can be used. Now there is a caveat there, which you mentioned, that you're not quite sure if we could do it while she's sedated in this patient. So the CAM-ICU is used to assess delirium, and part of the CAM-ICU used is your RASS. So this is the RASS scale that's on the screen here. So if the RASS score is -3 or higher, so a moderate level sedation or less, then you can do the CAM-ICU. So in this patient, what was her RASS again? -4. So that's deep sedation, so you're not able to do the CAM-ICU at this time in this patient. But we would want to continuously assess that, and if her RASS got a little bit higher, maybe if it got to our goal of -1 to 0, then we could do the CAM-ICU and assess for delirium in the patient. All right, so let's go into what our plan is going to be for sedation. So group 18, or not just for sedation, but for pain, agitation, delirium. Group 18, can you give us your plan here?
What should call them 18 Can we just decrease the propofol dose? Do we need to stop it?
Stop it and use
yeah, say that. Say that. Stop the propofol because of her triglycerides and use dexmedetomidine to RASS -1 or more. Sorry, this microphone is broken.
Easy to propofol from the triglycerides.
Where is group 18?
We're here, come on.
Go for it. Start pressing.
Okay, sorry, we're here.
That's okay.
So we want to discontinue the propofol because her triglycerides are high, and we want to use dexmedetomidine to target a score of -1, RASS -1.
Okay, so you want to discontinue the propofol because of her triglycerides and switch to dexmedetomidine and keep our same RASS goal of -1 to 0. So group 2, do you agree or disagree with this plan?
You did. No, it was mostly awesome. I just want to remember.
We agree with that plan. Okay. Did anyone group have a different plan for sedation?
You're one group.
So group 26, let me ask you a question. Does a patient that has a mechanical ventilator, do they So I hear a lot of, or see a lot of heads kind of shaking yes here in Athens as well. But they actually do not in any way have to have continuous sedation. Being intubated is uncomfortable, but it doesn't necessarily mean that you need to be sedated. So I've had plenty of patients that are intubated, are completely awake and alert, not on any continuous infusions, writing notes on a piece of paper. They can't talk, they can still communicate. So it is uncomfortable, it can be uncomfortable, but it does not require continuous sedation. You would want to have an option for sedation in a patient that is intubated in case they require it. But if a patient's RASS score is 0 to -1 with no sedation, then there's absolutely no reason to start sedation, and then you can cause adverse effects from your sedation. So it would be reasonable in this patient to just pause our propofol for now and kind of see what their RASS is off of sedation. It might be reasonable to switch to something like dexmedetomidine if we thought if they became agitated off of the propofol. It would also be reasonable to have a PRN order. So you could have an order for PRN midazolam and just administer a bolus dose as needed for agitation. But with this patient that's overly sedated right now, I think it would actually be best to stop our sedation and to kind of see what her exam looks like off of it. We know that she had a severe neurologic injury, so she may not have much agitation or much neurologic activity really even off of the sedation because her insult was so severe in the first place. Or she may just be calm even though she's intubated. So I think it's a common misconception that intubated patients have to have a continuous infusion of sedation. We have to assess sedation and agitation, absolutely, but they don't all need a continuous infusion. Are there questions about that?
I have a question.
Yes.
Okay, so she doesn't have to be sedated, and we all agree that she's over-sedated right now. My question is, if we take her off, should she get pain regardless? Like continuous pain? Did you say that already?
So, I did not say that. For treating pain in an intubated patient, right now she has a PRN order for morphine. Like I think you were alluding to, we could do a continuous infusion, such as a fentanyl, to treat pain. She doesn't necessarily need continuous analgesia, but again, we do need to assess it. So in her, we weren't really assessing pain, which isn't good. Our guidelines recommend analgesia first sedation. So let's treat pain first, and then if they're still agitated, then let's use a sedative. So in this case, we need to make sure we're assessing the pain. We can use the CPOT to do that. Based on the CPOT, we could try our PRN morphine at first, and if that treated our pain adequately, that would be okay. But if we did a CPOT and her CPOT score was 8 every time, which is a national score, then if every time we assessed it she was still in pain, then we might want to think about a continuous infusion. But you don't automatically need that because you're intubated. Good question. Any questions about sedation and analgesia? All right. So group 25, could you tell us what you would monitor for this patient? Okay, so we would monitor that's one of the components of the CPOT, right? So we would monitor our CPOT for pain, and facial grimaces would be part of that. And then we'd also continue to monitor our RASS and CAM-IC like we already talked about. Other things I might want to monitor for our patients who's mechanically ventilated would be a continuous oxygen saturation to make sure they're saturating okay. We might not have to repeat our arterial blood gas every day, but we'd want to do it if there's any kind of change in their status. We might also want to monitor a chest X-ray to make sure that their endotracheal tube stays positioned appropriately. And then one additional thing that we haven't talked about, you probably talked about this in your previous lecture on sedation with Dr. Brannon, but spontaneous awakening trials and spontaneous breathing trials. So you would want to do these and monitor the patient response to help you to determine if you need sedation, which we just talked about, and when they might be appropriate for extubating them. All right. Questions about the mechanical ventilator or sedation? So we have about 10 minutes left. I want to spend probably 7 minutes or so talking about our atrial fibrillation and coagulopathy, and then I'll have hopefully save just a couple minutes for any questions about the other problems. So as atrial fibrillation and the patient's coagulopathy and need for anticoagulation.
Okay, so she was on Xarelto for her AFib, but they held it, and she has a CHA2DS2-VASc score of 7, so she would need anticoagulation, but not yet because she just has a hemorrhage.
Okay, so good. So you calculated CHA2DS2-VASc score at 7. What does that indicate?
Her risk of stroke.
Okay, yeah. And so a score of 7 is pretty high. That indicates about an 11% annual risk of stroke. So there's an 11% chance that sometime in the next year she'll have a stroke if we don't give her anticoagulation. So with that, we have to also balance the risk of bleeding. Are there any assessments that we can use to determine a patient's risk of bleeding?
The HAS blood score, and hers was 5.
Yeah, what does the HAS blood score of 5 indicate? Do you know?
I'm not sure where it falls on the scale.
That's okay. It's also pretty high, so it indicates about a 9% risk of a major bleed over the next year. So she's kind of between a rock and a hard place, right? She's got an 11% risk of stroke, but a 9% risk of a major bleed. So what do you do? So this is a difficult situation to evaluate. I would agree that the CHA2DS2-VASc indicates that she does need to be on anticoagulation, although not right in this moment because of her bleed. But given her high risk of bleeding and high risk of stroke, this is the time where you would want to really engage the patient and family members in making joint decision-making with the medical team. Help them to be a part of that process, understanding the risks and the benefits of anticoagulation, and make a joint decision about whether you would continue anticoagulation afterwards. All right, so the other part of this that we talk about is the atrial fibrillation. So we have 2 different general strategies of treating atrial fibrillation. You remember rate control and rhythm control? So what strategy are we using in this patient? And do you agree with it?
Rate control?
Yeah, we're using rate control, which is the preferred strategy as long as the patient is not having symptomatic atrial fibrillation. What would the goal rate be?
Less than 80.
So there are 2 different potential goal rates. Less than 80 is the traditional goal, so that would be acceptable. The guidelines do recommend or say that it's okay to use a lenient rate control strategy, which is less than 110, as long as the patient does not have symptoms and they don't have heart failure with reduced ejection fraction. So this patient does not have heart failure that we know of, and it's hard to assess her symptoms right now because everything else is going on. But if we think that she's been asymptomatic with her AFib, then less than 110 would be okay. Less than 180 would not be wrong either. You could do the lenient strategy or the more conservative strategy if she has symptoms. And what medication are we using for rate control?
Metoprolol.
Yeah, metoprolol. So right now, she can't take anything by mouth, so we're using IV metoprolol, and as she's able to take things by mouth, we would want to think about switching that back to an oral metoprolol like she took at home. But no reason to make any significant changes there. That seems to be working okay. So one of the groups in the beginning when we were talking about problems also mentioned that the patient received the wrong dose of Kcentra, or 4-factor prothrombin complex concentrate. So I would kind of think about that here when we're talking about our anticoagulation and coagulopathy. So can one group tell us what the correct dose would have been?
About 4,000.
Yeah, so it's 50 50 units per kilogram, so for her it would be about 4,000 units. And she received 500, right? So much lower dose. So what you would do in this situation when you're coming in a day or two after this happened might be kind of difficult. If the patient was stable, if their CT scan showed that their hemorrhage was either the same size or decreasing, then you probably wouldn't do anything else for reversal. But if their hemorrhage was getting worse, then you might think about getting the rest of that Kcentra to get to what the dose should have been originally. All right. So we've gone through the three kind of major groups of problems that I wanted to discuss today, but I do want to leave a couple minutes for any questions that you have related to the other problems that we just listed. Are there any questions about any of these other problems?
For her stress hyperglycemia, what would you do about that problem?
Okay, so I don't know if the other campuses heard you, but the question was for the stress hyperglycemia, what would we do about that problem? So the SCCM, the Society of Critical Care Medicine, has guidelines for glycemic control in ICU patients. And the goal on blood glucose level is maintain at less than 180. So in this patient, we would certainly want to monitor with point-of-care testing, so do AccuChecks probably every 6 hours to monitor her blood glucose. And then it doesn't look like it's going to be much over that, so we might just give her some sliding scale insulin to cover any blood glucose checks that are over 180. Good question. Any other questions about her problem? Yes. Good. So for restarting anticoagulation, I would go back to our guidelines for hemorrhagic stroke that gives some suggestions on that. But to start full anticoagulation, you're typically going to want to wait a month to start that back. To start DVT prophylaxis, you can actually start that back in as early as 1 to 4 days, as long as the bleeding has stopped and it's not getting worse. A lot of times we won't be comfortable with that because we'll want to just monitor them closely and maybe wait a little bit longer. But you can start it as early as 1 to 4 days for full anticoagulation, wait a month. Any other questions?
I found that like dabigatran or apixaban have less or lower rates of bleeding than rivaroxaban. Do you think that's like significant?
I do. So that's a really good question. And so dabigatran has high rates of bleeding in some scenarios. The one that is shown to really have usually the least rate of bleeding, specifically GI bleeds, which isn't the same here, but is apixaban. So if for a patient with a higher bleeding risk that we want to use a DOAC, many providers would choose apixaban because of a somewhat lower risk of bleeding, although that's not specifically intracranial bleeding. Any other questions?
I have a question for the DVT prophylaxis.
Sure.
You said we can start again after like 4 days.
You can.
So do you use like heparin or do you use like IPC?
So you could use IPCs now. We wouldn't have to wait on that. So we could go ahead and use IPCs. And then determining whether you would start subcutaneous heparin versus enoxaparin after a few days for pharmacologic prophylaxis would be the same as your decision making for any patient. So you might look at either renal function, decide if you're going to want to dose 3 times a day versus once a day. Other questions? So this is a very complicated case, but it's similar to one that you'll see on your APPEs. You will not see anything nearly as complicated on your practical, so don't worry about that. But if anyone does want to kind of see my workup for the rest of the problems that we didn't discuss in detail, or if you think of any other questions, feel free to email me if you're on another campus, or to talk to me after class, and I'm happy to show you my complete workup, or just help you work through either parts of it. Because this is what you'll see in practice in just a few weeks. All right. Well, thank you guys very much. And again, just reach out if you have any questions.
Are you going to post the slides?
Yes, I can post the slides.
I saw that and I was like, that was too good not to share.
It was funny. It wasn't